There we go. Sorry about that, folks. Just a small technical glitch. It's all on me, not Holly's fault at all.
Okay, there it goes. Good morning.
Good morning. No matter how many times we do this, there's always going to be some little glitch. Welcome to the world of nonprofits and volunteers. This is the part where I say what, Penny?
Yeah, blame it on the COVID. What?
No, we say, this is where we say, we hope you give us all a little bit of grace. We're doing the best we can, and we're glad that you're here. We're up to 240 people in the event live today. So fantastic. Thank you all for being here. Penny's going to kick us off. She's our MC. Go ahead, Penny.
Okay. Good morning, everybody. I want to thank all of you for joining us this morning. For those of you who have been longtime participants, could you imagine if we were doing this live today? It would have been a disaster. So we're so glad we'll be able to talk with you today virtually. So, and because of this wonderful technology, we are able to present to you this very timely topic. So the title this year is A Year in Mask, the COVID Pandemic, Race, Racism, Vaccine, Vaccination. What do we need to know? What do we need to do? So, as Lisa said, I'm Penny Franklin. I'm the president of the community group and of Montgomery County. And the community group has created and brings you, we sponsor the Dialogue on Race. This is the 9th year of our Dialogue on Race, and it's amazing the work that has been done. So don't let the word dialogue fool you, because this is about action. So we have over 430 folks who have registered for this conversation today, and we want to thank each and every one of you for participating. We want to thank our community sponsors, our partners. So the government of Montgomery County, the town of Blacksburg, have been wonderful in supporting us throughout the years on this very, very important topic of racism and how we help to eradicate that here in Montgomery County and across the country. So we are thankful for them for their support to help underwrite the Zoom technology that we'll be using today. So today we have two very distinguished panelists, Dr. Abraham Billy Hardee and Dr. Pete Guerrera. But first, I want to thank our moderator for this morning. That's Holly Lesko. So Holly is, let's see, let me tell you what Holly's credentials are.
Holly's amazing. Okay. We love Holly.
Yes. So Holly is, I'm sorry, lost my script. So Holly is a liaison with the school system, working with the task force in the New River Valley. And we want to thank them for the wonderful job they're doing, trying to make sure that we are all getting our the best information and being supported through this COVID pandemic. So, but first, Lisa Garcia is our tech guru, and she is going to give us all some pointers on how we're going to be using the technology today. So, Lisa?
All right. Thank you, Penny. This is the part where Penny's like, oh, good. She's going to be 2 minutes and then she's gone because I can be a little noisy. All right, folks. So here's the deal. Welcome, welcome again. If you look at the bottom of your screen, you can see a couple of different things. I believe you can see the participant count. We're up to 254 people here today live. This goes beyond my expectations. I was saying, well, maybe 200. Martha Ann Stallings, one of the members of our steering group, said, oh, easily over 250. So you go Blacksburg, Christiansburg, and across the United States, actually, we have people logging in. So thank you for being here. The other thing you'll note, and a lot of you are doing this, I can already see it. So on the bottom of your screen, there's a little thing that looks like a speech bubble. If you click that icon, you'll get a chat window that'll open up. Inside the chat window, we want you to be engaged, ask questions of your peers in the audience. We have several volunteers that are very well informed about this topic, that if you ask for a resource, for instance, some of the things that Holly Lesko and her team are working on, we have links to those websites. We'll put those in the chat. So feel free to connect with people in the chat, give a shout out to our panelists and thank yous to them. We really appreciate that. The other thing you'll see at the bottom of your screen, or you should see, are two little speech bubbles on top of each other, and under that, the letters Q and A. If you have specific questions you'd like for our physician panelists to answer, please put those in the Q&A, and we have folks monitoring that, and we'll try to get those to the doctors. We won't be able to have time to get to every question, but we will make sure they get that. And if we can get back to our audience through email or whatever, we'll answer those questions as best we can. If you have any technical difficulties or questions, put those in the chat as well, and we'll be there to help you out. We are so glad you are here. We're recording live today, the event. If there's any sort of issues, we have security, so don't worry about that. We're going to take care of any problems we have. Thank you for being here. Penny, Holly, back to you.
Thanks, Lisa. So again, I want to thank each and every one of you on behalf of the community group for joining us. And I want to thank all the steering committee members of the Dialogue on Race for their hard work and time, and all of the support we get from our community volunteers to help us bring these webinars to you. So Holly, I'm going to turn it over to you.
Thanks, Penny and Lisa. Just so you know, we're going to spend about the next hour or so hearing from our distinguished panelists for their insights, guidance, and advice regarding the coronavirus or COVID-19. We're going to be talking about vaccine development and distribution and what they are, why they matter, and what to do, who is involved in that work, and of priority importance for the Dialogue on Race, about how race and racism are inextricably woven into the pandemic specifically and healthcare in general. All of it so that we as community members can be better equipped to address issues related to the pandemic and to identify and combat racism in healthcare. If you have questions, as Lisa has explained for our panelists, please feel free to use the Q&A function. If you have general comments or resources to share, it's always great to learn what other people have learned with the audience or with others. Please put that in the chat window. Our team co-hosts are monitoring both chat and Q&A, and we'll make every effort to make sure your questions are noted. If we run out of time, as Lisa said, we'll make sure to forward questions to panelists as we've already indicated. So now I would like to introduce you to our panelists, and I'm going to let them appear on the screen so you can see their faces. Okay, I'm honored to introduce you to our distinguished panelists. Dr. Abraham Billy Hardee practices medicine at the Community Health Center of the New River Valley and MedExpress Urgent Care. He is Associate Chair of Family Medicine and Rural Primary Care at the Edward Paya College of Osteopathic Medicine, where he received his osteopathic medical degree. He is a Hokie and was a member of the Virginia Tech football team. Dr. Peter Guerrera specializes in family medicine. He received his medical degree from the University of Central Florida College of Medicine, where he graduated summa cum laude. He is serving as a physician at the Community Health Center of the New River Valley. He joined the staff there in the summer of 2019, just in time. Guerrera is fluent in English and Spanish. Dr. Guerrera and Dr. Hardee will be making their presentations using slides that you will see on your screen. You can use the chat and Q&A, as I said, function at the bottom of your screen throughout their presentation to ask questions as they do their presentation. We will devote the last half hour of our time together to address as many of these questions and comments as possible. Questions we do not have time to cover today will be addressed in the follow-up communications. Now let me turn it over to our distinguished guests, Dr. Billy Hardee and Dr. Peter Guerrera. Gentlemen.
All right, take my mask off. All right, well, perfect. Thank you so much for having us here Saturday morning. We're excited to get a chance to present this information to you all today. I'm gonna share the screen. If someone can give me a thumbs up or a yes, we can see the PowerPoint presentation would be very helpful.
Yes, we can see it. Thank you, Dr. Guerra. Dr.
All right. All right. Well, perfect. So from this point on, everybody knows that Dr. Guerra and I are both physicians. We agree on that?
Yes,
All right. So we're going to go by Hardee and Guerra moving forward. So that way it's not a whole bunch of doctors going back and forth. All right. We want to make this something that is fun, something that is educational, and something that is long lasting. All right. That is our focus for today. Now, in true movie-like fashion, though, we got to save the good stuff that a lot of people are interested in. We're going to save some of that information towards the latter part. That means with the COVID vaccine distribution, how it was made, et cetera. We're going to save some of that to the end because we want to build on that. All right. So I think they gave us about 45 minutes or so, maybe 50, to present this information. So we're going to go through quite a bit of items for you back and forth. Dr. Guerra and I work together in the clinic, hence why we're sitting so close together. Also, too, why we removed our mask. We, fortunately enough, have been fully vaccinated as healthcare providers. So we're ready to move forward.
sir.
All right. So you can see all the hands on deck, right? So a year in mask calls for all hands on deck. This is going to be Guerra and myself presenting this information.
So just some disclaimers. We don't have any financial obligations or contributions tied to this presentation. It's not meant to supplement or really provide direct information as it relates to personal health needs. So we just recommend that you would address any personal health needs with your physician. And of course, we're recording this information, so if you wanted to review it again, that's great. And we hope to get to as many questions as we can about the presentation and answer those questions as needed. We're definitely available to answer any questions you have about it in the future.
All right, perfect. So research says if we make ourselves personal to the audience, then you're more likely to listen to what we're going to say. So we figured we're going to put the reason why we're here is because our family's here. So obviously our corresponding family's there, matched up to actually the side of the table we're sitting on. I would like to say that's because we're organized, but sometimes life works that way. All right. And so also I want to say this too, as you can see in the picture with Guerra and his family, his wife is holding something that is her belly. They have since had their baby. So they are doing well. So that's awesome for him to be able to take some time out to come spend with me as they have a newborn at home. So also too, there is a handout sheet with a lot of the links that we're going to be discussing today because there's a lot of information. We want everyone to have access to that. All right. So you can review that on your own. All right. Because there's a lot of detail and some of it is pertinent, some of it not so much. All right. And then at the end, once again, we're going to answer questions. But I didn't know we were going to have homework. They said if we don't answer them now, they may send us questions later. So I didn't know about that part. We may have to discuss that later at the end of this. So let's jump on in. Objectives. So anytime someone has a presentation, we want to present objectives, but we figured let's do it in a fun way. We want to label these objectives as it relates to national heroes to us in our culture. Outside of the people that you know very much about, you could, yes, it being Black History Month and Martin Luther King and things of that nature. We want to talk about some other people in history and how it relates to the topic that we're going to be presenting today. So for example, so our objective number one, why racial disparities? Why even talk about it? We're going to talk about Jose Luis Alberto Munoz Marin. Also, when we talk about biases that are ingrained in our culture and it oftentimes affects our ability to understand and to grasp what cultural competence is. We're going to talk about Betsy Coleman.
And our third and fourth objectives will be social determinants of health and COVID vaccine and how COVID has affected our community and what we can do to help our community with this public health problem. Vivian Thomas will be the person in history we'll use to address the objective of social determinants of health, and Roberto Clemente will be the historical person we will use to address COVID and humanitarianism.
Awesome. Now, one thing you realize, Dr. Guerra is very soft-spoken. So I have to make sure I tone it down so that way I'm not yelling at the screen. Sometimes I do that. All right. So constitutions, right? What are constitutions? Why are they important? Well, what we agreed on was constitutions are very important. And it's important for us to start this talk off with looking at some constitutions that we value. Now, of course, as medical providers, but as humans in general. So we really enjoyed and we really appreciated the constitution that the WHO uses. Now they have 9 different tenets, but I have 2 here on the screen. Health is a state of complete physical, mental, and social well-being, and not just merely the absence of disease or infirmity. How important is that for us as we see now with the situation we are in now, and such as a pandemic, right? Everybody knowing that we're all in together. Oftentimes we say that, but that's not always how we practice that, right? And then of course, it's important for us to be able to enjoy the highest obtainable standard of health is one's fundamental right. Okay, it's not a privilege, it's a right. We should all have the ability to have that, irrespective of your color, i.e. race, your religion, political belief, your finances, all right? And then of course, your social condition.
Absolutely.
All right, so moving on.
So we chose to use this slide to represent what we think is a very important discussion in our current time in history. You can draw many conclusions from these photos, but what we think it represents at the very least is a transition from historical, private, solo practice to team-based practice, which is more patient-centered and oriented, and a transition from the original thought processes focusing on disease and how they affect death and patient outcomes, also known as morbidity and mortality, to focusing on patient factors that have significant effects and impacts on the patient's health overall. That is social and cultural factors which may not have been historically addressed. And we hope to talk about that here at the first part of the presentation.
Absolutely. So, and getting into that, we got to make sure we're not doing some fusions, meaning fusion of diversity and racial and cultural disparities with gender disparities. Not doing a fusion with diversity, racial and cultural disparities with sexual orientation disparities or with mental health disparities. So we want to make sure that everyone understands the focus of this topic, but understand that, of course, there are many other disparities that are out there. And we may hint on that a little bit here today, but we're not going to try to deviate or try to merge too many things together and to lose the information that we have. All right, so this slide, oh, we love these graphs and bar charts and things of that nature. What is this? I got to know who the audience is. I need to know, and Dr. Guerra needs to know, who are we speaking to? All right, so who are we speaking to? Well, we're speaking primarily to people here in Virginia, which is made up of 95 different counties, 38 independent cities. The Commonwealth is divided up into 5 different health regions. All right, of course, we are the Southwest Virginia region. All right, and then our population is roughly about 8.6 million, somewhere around that way. All right, depending on, I guess, people getting born right now, right? So that may change a little bit, right? So we have a large population of individuals. Keep that number in mind, that 8.6 million. Keep that in mind here as we move forward. We also know that older individuals are living in Southwest Virginia than they are on quote unquote Northern Virginia, all right? And then our demographics, we're looking at about 64% are Caucasian, about 19% are African American, and then 8% are from the Latin community, and then 6% is from Asian community. Moving forward, we're gonna use the term white, we're gonna use the form black, and we're gonna use the term Hispanic. All right, so that way use consistent terms moving forward. All right, and you can see here, once again, we're not going to do a fusion, but you can also see, looking at this slide, the breakdown as it relates to male and female outcomes as it relates to education. So once again, there are disparities outside of racial and cultural disparities. There are significant gender disparities as well. So you can see that on this chart, right? So once again, hinting at it, not getting distracted, okay? All right, so our first person we're going to talk about, this is Mr. Jose Luis Alberto Munoz Marin. And he was a Puerto Rican political leader following the footsteps of his father. He was instrumental in gaining the self-rule and later the Commonwealth status of his country in Puerto Rico. Now, we of course know who's on the left side. He was an important gentleman, JFK, right? And Mr. Marin was also very important to his people, his culture, right? And their development of a independent, but at the same time, a diverse culture there in Puerto Rico. So we use him here because we need to understand the importance of racial disparities.
So before we start talking about disparities, we're going to first talk about diversity. We will talk about what diversity means, how it affects health, etc. But we wanted to start the discussion on diversity and eventual disparities with some quotes which we thought stood out, as this topic has been on the minds of people in history probably since the beginning of time. One that stands out to us is that this is not a matter of politics. It's a matter of not a matter of political correctness. It's a matter of growth, growing as humanity, working to help each other improve better society and have better health outcomes for our community. The quote that I like from here is that inclusion is not a matter of political correctness. It is a key to growth. And that was from Jesse Jackson. You can see the other quotes here. We found that this was a good way to start the discussion. As you can see, people have been thinking about this topic for a long time, and this is a pivotal time to talk about it given the current situation in our country.
Absolutely. Diversity is important to understand, and also understanding diversity comes in many shapes and colors, right? So in different languages, there's over 6,500 different languages, over 60,000 different types of trees. Shoot, there's more than 34 pairs of Jordans. I think this data may be a little old. I think there's some new ones out now, but 34 different types of Air Jordans, all right? If we look at genetic diseases, there's only 4 types. However, those 4 types make over 6,000 genetic disorders. Single gene mutations to multiple gene mutations to chromosomal to mitochondrial mutations. Diversity is around us all the time. All right. They bounce away appropriately, I guess. All right, here we go. Now, we also know that there's diversity within a diverse culture. Right. So I love the hyperlink that comes with this. And I think I attached that to the worksheet that everyone will get a copy of. We look here, we have a Hispanic lady here to the left that says, oh, you don't speak Spanish, right? Or we look at the lady in the middle. It's like, why do you look so fair skinned compared to your mother? Right? Or wow, you talk wider, you speak well, right? Things of that nature, right? That people will say. So there's diversity within a diverse culture, and that's important for us to understand. Oftentimes we use the word race, and we're going to talk about that. We want to transition that word race itself to maybe, instead of saying race, what's their culture? That's got so much more significance of identifying someone opposed to just saying their race. That's a color thing, which may have no semblance to this young lady here, who may not even grew up in a Latin American country. She may grew up right here in the States. That may be why she doesn't know Spanish. Okay, so that's important. All right, this slide here, all right, we're on now, I think we're slide number 12. We're a couple minutes in. I think our pace is pretty good. All right, but we wanted to look at an older study from 2005 where it looked at race or social economic status versus race and social economic status. Is there a difference? All right, the debate between the two, how does this depict someone's health trajectory? This is a really neat study that was done. It's an older study, but it's a really neat study that we're going to focus on. It came from the Health Affair magazine, which is a great magazine to learn about the status of our country as it relates to healthcare. So anything you want to add on that one, or kind of jump in on the next slide, I guess?
We're good, yeah.
All right, perfect. So we got our 3 boxes here, right? So are we saying that because of an individual's biologics, meaning because of their race, because you are of Puerto Rican descent, you are going to get this, this, and this? Or are we saying because you are Hispanic, automatically your class is equal to this? Or because I am Black, my class in life is going to equal this because of my race. Once again, race. Or race and class are separate variables, and class and race matter, all right? So they're separate, that they make that complete person, that culture, right? So health disparities are not a biologic proxy, are not a biologic nor a proxy for class, all right? And we're gonna see what that looks like here. Dr. Guerra is gonna break that down for us.
So an interesting study here, some older data, but still worthwhile, from an article from 1997. It compared birth weights of babies born to mothers who identified as white in the US, and mothers who identified as Black in the US, and mothers who identified as Black in Africa. There's two representations of the data here. We see a plotted version of the data on the left side of the slide, and then a table version of the data. But what we really want to point out, and what the article identified, is that African-born Blacks and US-born whites, that is babies born to mothers who identified as those respective races, had very similar birth weights. However, US-born Blacks, that is babies born to mothers who identified as Black, had lower birth weights. This suggests to us that there's some other components of the culture leading to the discrepancy in weights of these babies at birth that beyond the skin tone of the mothers, that are contributing to this health outcome, which tells us that there's probably some broader aspects to culture that we need to consider when we're caring for patients and thinking about community health.
Perfect. So looking past their color, so looking past an individual's color, so race equals the class that you're in. So in this slide, coming from the same study, okay, so what we want to look at, not the same study as the one with birth weights, I want to make that clear, but looking at the 2005 study, all right, we can see now that there's a closer association with lower income whites and lower income Blacks as it relates to lower income whites compared to middle class or upper income white individuals, right? So there's a closer association here. I have a quote from W.E.B. Du Bois that I'm just gonna basically put this whole picture together as it relates to race, putting someone in a certain class, okay? And that's not always the case. It doesn't determine your class in life. I am an African-American male. I am a physician. I have a PhD. I work in a clinic, right? And I work at a medical school. Dr. Guerra, he's of Puerto Rican descent. He works in a medical clinic. He is an MD, right? His significant other is a physician as well, right? So his race didn't determine his class. Now, these are small representations, but we want to let you know that's the parallel that we're trying to show here through this study. Now, moving forward, they said race and class are variables. They're very important. So the race should not be conceptualized as a proxy for class, all right? Race disparities should not be analyzed without simultaneously considering the contributions of class disparities, i.e., where did you grow up? Did you have formal schooling? Did your parents have formal schooling? What makes that up? What were the resources that were available to not only your parents, but to you growing up? All right, and then potential interactions should be considered between race and class based on disparities. Now, this is a lot of kind of nuts and bolts. And I know the question now is, hey, this is some old information, man. 2005, a long time ago, right? So we could even extrapolate that to newer, more current information, especially as we're looking at COVID.
Absolutely.
All right. So there was a study that looked at, it was a resilience survey that was performed in Chicago, December 2020, to be exact. So what they were looking at is some of the limitations for individuals getting information about the virus itself. And then ultimately, what are their limitations to be able to get set up to get the vaccine, right? And what they were able to identify, there are so many unmet needs in these cultures, that being the African-American or the Black culture, along with the Hispanic community as well in Chicago alone, right? So yes, old data, but we can see a reoccurring theme, right?
Absolutely. So we've touched on diversity and started to talk about some social factors that affect health. We wanted to transition over to biases, and we wanted to use the historical figure Betsy Coleman as our historical figure to represent this objective. A big background on her: she's the first pilot of U.S. origin of African descent to fly in the United States, who had to overcome many biases, including at that time identifying as a female and being of African descent, and which limited her opportunities to learn to fly in the United States. In fact, she had the goal of flying and was so determined to reach her goal that she learned French to go to France and learned to fly in France, where she was able to train, and she overcame some of the biases which she experienced in her time.
That's a lot.
It is.
That is a lot, right? So what does that mean? So as we're talking about our biases, we got to understand, we have to address our individual areas that we discriminate against other people, our own personal biases. So we can look in the Family Practice Management Journal, which is a journal that Dr. Guerra and I enjoy. I get used to calling him Guerra, all right? So that we like to read and learn about. It talks about self-reporting from physicians. And in 2017, a survey of more than 800 US physicians, 6 in 10 reported absorbing offensive remarks about personal characteristics in the past 5 years. So including physicians' race, their gender, their ethnicity, their age, their weight, etc. Right? And then 2015, there was a study with over 5,300 hospital workers found that 5,576 incidents of verbal abuse by patients or visitors over a year's time, so 12 months, right? And then you had 2,200 physical threats and 1,100 incidents that were also recorded there as well, right? So there's a lot of discrimination that goes on, say, not just in medicine, but think about your own workplace. Think about in your hiring practices at your company, right? Some things that may not be intentional, but they can be discriminatory against certain individuals, right? We could don't want to do fusion, but we can even think about handicap access, right? Someone may be wanting to apply to your company, but if they realize it's so cumbersome for them to be able to get access to the building in itself, you may be compliant with all the rules, right? All those requirements and things of that nature, but it's so difficult for those individuals that have limitations to get access to the building or get in or to move around easy, right? That can be a discriminatory practice that you may not even be aware of. Once again, being careful with the fusion between the two. All right, so we got more self-reporting. So we got about 24% of physicians state that they document such interactions in the medical record as we related to the studies on the other page, right? And only 10% reported incidents to the advisory, to their administrators, right? And then 60%, they didn't even know if there was a formal process, right? So as a medical provider, we know that patients they come to us in a vulnerable state. Oftentimes we get a wellness visit, but if we're in the hospital setting, as both of us have worked in the hospital setting, and the patient is under stress and things of that nature, so they may be frustrated, they may be annoyed, and then when we're saying things that they may not agree with, right, then that makes it a little bit more of a heated discussion. So now the question is, so how do we handle this?
Yes, so the key is really to probably de-escalate the situation. And we put some points there on the slides to consider if you come across the situation in your own work life. But for us, for example, if we experience a situation where we might feel discriminated against as healthcare providers, the best thing for us is to approach it from a patient-centered standpoint, understanding, we're just going to do what's best by the patient first and foremost and be objective. And how you do that is to avoid taking things personally. You take time out, step away from the situation, and allow time to process the situation before responding instead of reacting, and try not to be emotional about the matter as much as possible while still responding with empathy and trying to understand that patient's perspective and where they're coming from their own cultural experience.
Absolutely. And then once again, you got to know your audience. We said that from the very beginning, knowing our audience. So using our field of work as an example, I have a patient that I follow with to this day. Or by our second meeting, she told me, she said, I'm one of the best colored docs that she's ever seen. And she said she's only had one other one, but I'm one of the best. So I guess I'm 1 out of 2. But she was an older female from right here in Southwest Virginia. I believe in my heart of hearts, she meant she didn't want to be discriminating against me at all, right? She didn't mean to be ugly or mean. She was giving me a compliment, right? So I had to do what we said here, right? I had to not take it personal, take a time out, respond, not react. And I need to check my feelings at the door, right? Because they still follow with me. So I must be doing all right, John.
Certainly are.
So understanding biases, right? So studies show that healthcare professionals, we have the same level of bias or implicit bias as the general population. Why is that? Because we're just like you, right? We just got a degree that says we can do medicine, right? But we're regular people just like you. As a teacher, right? Teachers that are listening, you're just like everyone else. You have a degree that helps you teach young children, or maybe even professor at the college, right? We have our biases. The biggest thing is we need to understand what our biases are. I know what my biases are, so I have to check myself as I encounter students, right? At the medical school or here at VCOM, right? I have to check myself as I get ready to work with the student, and I may have a bias towards that individual. All right, we're going to get to that here a little bit later. Providers with higher levels of bias are more likely to demonstrate unequal treatment recommendations to those that have that are underserved populations, or for pain management, for that example, or showing empathy to someone, especially to minority patients, right? If I have a patient that shows up on the schedule and I'm a busy day, we're moving around, we're seeing patients, doing our thing, and then I have someone comes up, I'm gonna say Arabic. They're speaking Arabic, all right? Or Mandarin. I don't speak either one of those languages. Now I gotta make an effort. Do I go and try to talk to the patient through broken English Mandarin or broken English Arabic? Or do I get on language line, which takes some time to dial it, which takes some time for interpretive services? I don't get paid any more or less for using that service. However, I'm treating the patient.
That's right.
Right? And that's so important for us to understand. That's important for you to understand in your place of work as well. And then also saying, hey, there's a lot of different stresses and time management pressures, Zoom calls, right? A lot of you guys are able to work, guys and gals are able to work from home on a Zoom meeting. We often realize we're scheduling ourselves more meetings now because it's easy and accessible, right? So that's important as well. So here's some resources that we wanted to put on here. So Dr. Guerra and I said that we wanted to look at this, understanding that yes, there are biases, but also too understanding what implicit bias is, and then having a little mnemonic. So in this implicit mnemonic, as you can see right here on the left-hand side, educate, expose, approach. So introspection, mindfulness, perspective talking, so learning to slow down, to individualize the situation, all right, or the individual, and then check the message, all right, institutionalize fairness, and then takes two, right? So also too, not only understanding this mnemonic, but what are some resources that are available? Once again, we pulled these things here from the AFP, which is American Association of Family Practitioners, or Family Physicians, excuse me. So here's some resources here that you could look at in regards to ways that you can learn about changing your biases that you have. I like this 21-day one. I looked into this one, something I wanted to implement here in the place that I work, or the place that I work, a couple different places. And then health, equity and diversity, and social determinants of health and family physician management, right? So there's different resources here for people.
Very helpful. So we've had a lead in with diversity, talking about free cultural points, but what we wanted to do before we move forward, talking about how we can make some positive change in this matter, not only in medicine, but in our community, we wanted to lay down the definition. We obtained this definition from Georgetown. You can see the source there. We wanted to first say, what is culture? Well, it's a set of congruent behaviors, attitudes, and policies that come together as a system and work effectively in cross-cultural situations. Being competent understanding the culture is very important. That doesn't mean we're going to understand everybody's point of view, where they come from. Competence is being aware of the culture and how it can affect not only health outcomes, but just everyday life for a person, and then coming to an agreement to learn more about each other so that we can better the world.
All right, perfect. Cultural competence is key. And one of those things that we do, once again, we mention these things, but we want to show some resources, right? As it relates to not only understanding your bias, but understanding cultural competence. As we make that transition from the understanding that, yes, there's diverse culture and the importance of diversity, changing it from being a race to being a culture, right? And understanding different cultures within, or diversity within a diverse culture. So language line are good options for you. It doesn't matter if you're medicine or not. You're going to encounter individuals that English is not their primary language, or they have limited English proficiency. All right. So language lines are something that's really big to use. Then we have also your resources for minority literature that you could use here, and then your practice setup. your work setup. If you're wondering, I just really wish we could increase diversity here at our business. But then when you look in your waiting room, or you look in your lobby, or you look at your structure, and there's nothing in your office that says anything about diversity, all right? Even down to the literature that you have on your table. If every magazine you have is about health and fitness, and you have a skinny Caucasian woman running on the mountains, right? However, you're servicing a bariatric office. That doesn't make any sense. And that can also deter individuals. What are your office hours looking like? You wanting to have a working population, or you want to help those that are shift work, or you have an extended hours for people that are working second, third shift? All right, are they able to get in? And then of course, the final stage is, are you demonstrating that in regards to the individuals that you're hiring? We want to hire qualified individuals. I want the clinic that Guerra and I work for to have the best physicians possible. They want to be qualified individuals, but we got to have a diverse staff if we want to have a diverse population. All right, that's so important. And that's hard to do in Southwest Virginia. It's challenging, and I understand there are limitations with that. So we have to understand, hey, this isn't personal. Some of this stuff is stuff that we have learned, and we have a list of many different items that we use in medicine that can be discouraging as someone who is Black, to read some of the values, some of the scores that we use, some of the indices that we use to calculate things. So this is a fantastic article that came from the New England Journal of Medicine called Hidden in Plain Sight. And Dr. Guerra is going to talk a little bit about this.
Yeah, Hidden in Plain Sight. It's a thought-provoking article from the New England Journal of Medicine, very reputable medical resource. The second part of the title is actually reconsidering the use of race correction in clinical algorithms. What it means is we have several algorithms which either assist in making medical decisions or maybe support medical decisions that may be using race as a factor to stratify risk. The article suggests and gives good support for reconsidering the use of race due to lack of evidence to indicate that race in and of itself may be as important as, or more important, that is, than other risk factors for increasing risk for certain outcomes. So one example, for example, that we can look here in the middle of the screen, I'll move the mouse, I don't know if you guys can see, but the one that says VBAC, the vaginal birth after cesarean section, that is in women who have a history of cesarean section trying to achieve a vaginal birth in a subsequent pregnancy. Race is used in one of the algorithms to stratify the risk of needing a secondary C-section. However, the study that was used to develop that algorithm also found that other risk factors, such as marital status and insurance type, also had a correlation with increased risk for cesarean section. And those factors were not included in the algorithm. And there was no reasoning given by the creators of the algorithm for not including those factors, or for including race solely as a risk factor for subsequent C-section. So it's very important that we consider other cultural factors, not just race in and of itself, when we're looking at risk of patients for certain health outcomes.
Absolutely. And we oftentimes, when we talk about health disparities, we'll jump on a Tuskegee and things of that nature. But there are still algorithms that we are using right now, right? So American Heart Association, heart failure risk score, all right? There's the kidney donor risk index. So African Americans are at high risk of kidney rejection, all right? Meaning those that want to donate a kidney, it's rejected. But African Americans are most likely going to get a donated kidney from another African American. So not only are there a limited supply, but they're oftentimes going to get deleted, or oftentimes there isn't going to be one available to donate to them, or the kidney that you want to donate is rejected for certain criteria, right? So there's a lot of things there. Once again, it's not personal, but these are things that are learned or trained, and we have to break these cycles of putting everybody into a race box and then look at culture in itself as it relates to health. All right, so moving forward, Vivian Thomas. Vivian Thomas was a lab tech who was essentially received his honorary doctorate at Johns Hopkins, secondary to his involvement with blue baby syndrome or tetralogy of Fallot. And he worked there for 35 years, and he was a pioneer. He had many limitations that did not allow him to become a physician, even though he was an integral part of this surgical development on the heart, which used to be a no-touch zone. All right. So with that said, we're kind of merging now from diversity understanding our biases, but now we're moving into what are the social determinants of health. So all the crap that happens outside of the clinic, or all the stuff that happens if you work at tax place, all the stuff that happens after you crunch the numbers, when they get into a car, they have to catch a bus, or they have to catch a ride with their friend, or if they get home and they have multiple individuals living in their residence, or they have a low-paying job, right? So what are these other things that affect them? All right.
So we've probably seen some version of this picture, or each of these pictures, as we have studied equality, equity, justice, or just in this current cultural climate, this current point in history. But we just wanted to point out the fact that there are differences between equality and equity and justice. As an example, you can look at the picture on the left with the bicycles. Everyone has the same bicycle. However, that bicycle does not work for the needs of all of those individuals. That would be a picture of equality representation. Equity would be providing the correct instrument for the patient or the correct resource for the person in whatever life situation that they need in their individual situation, so that they can prosper and thrive, which is a very important part of the discussion at whole, and especially the current situation of our history.
Absolutely. Equity and quality is kind of a newer term for a lot of folks, being aware to the terms, but also too understanding the different social determinants of health. So I mentioned at the very beginning, there is a close association between lower income whites and lower income Blacks, more so than it is to their middle class or upper class counterparts, even though they're of the same race. And I mentioned there was a gentleman by the name W.E.B. Du Bois had a quote, and I want to read this here. It says, one of the main functions of racism in the United States has been to divide people with common class interest so that they are less able to struggle politically in their common interest. That's very important. Low-income whites, low-income Blacks have more in common. However, they're often divided on their political beliefs because of certain cultural factors that's there. Now, that often plays a role into everything you see to your right? Living in the inner city, right? So we talk about, oh, I don't know why when it comes to vaccines, we can't get vaccine to these individuals, or why is this set group of individuals at a higher risk of developing COVID? They probably don't wear a mask anyway. Well, look where they're living. They're living in a big old box with multiple people stacked on top of each other with poor ventilation. Or we can take that to what we're used to seeing here in Southwest Virginia, multiple individuals in a cylinder tube, i.e. a mobile home, right? So airflow is poor. One person may have positive for COVID, but there's 4 other individuals that do not have it yet, but they will because of poor living conditions or poor ventilation. All right, we talk about, oh, obesity is such an issue. This food here, all of this stuff in this bucket right here probably costs under, what, $10, right? But you put some fruits and veggies in there, you up the price now to maybe $20, right? So limited access to healthy foods, all right? And then of course I put over here, taking down of monuments is another social determinant of health, right? This goes into that, where you live, what is your upbringing, right? Disabilities as well. All right, and then we also looked here in the Family Practice Management Journal that we've mentioned before, right, as it relates to medical care, right, and what we actually do in the clinical practice in their actual life. You want to talk about that a little bit?
Absolutely. So we understand both from the research we've studied, literature that's available, and from our personal experiences that while what we do is very important as healthcare providers, it's not the most important thing. There are many factors in a patient's life that will have much more of a stronger influence on their health outcomes, including the examples we've listed here, but these can range from access to healthy foods, ability to afford them, understanding how to read and how to read a label correctly to correctly intake, to make the correct portion of nutrients, if they have diabetes, or if they have high blood pressure, or feeling safe in their work or living environment, such as feeling safe enough to go for a brisk walk outside and to be able to care for their health on their own, and a slew of other factors.
Absolutely. So once again, at the very beginning, I think it was slide 2 or 3, we said, hey, the good old days was one provider seeing one patient, opposed to now where it's a team approach. He said, well, that just makes medicine complicated. It does. It does make medicine more complicated because we realize through time that we are more complicated individuals. We can develop better health outcomes with a team approach, right? So having a referral coordinator opposed to the physician or nurse trying to set that up. Having care coordination team helping our patients get assistance at home with medical health bed or a Hoyer lift at home because they have some movement limitations, all right, transitioning from the bed to their wheelchair, etc. Having a more team approach is important. So yes, the 10 to 20%, we tell them, hey, this is the med, this is how you need to take it, this is what you need to do. We can't just wipe our hands of it and put that patient out the door. It's very costly. It takes a lot more time, but it's the most advantageous for the patient. All right. Social determinants of health. So a study that shows this is looking at a study from the CDC, Health Disparities and Inequality report. It's one of my favorite reports here. I'm going to make this very easy and straightforward. It was a 2-part report. So they did a part of it in 2011, which looked at 22 different factors that make up health disparities. The factors are here on the bottom left, looking at the leading causes of premature death, having social, demographic, and other disparities in health outcome, effective and feasible interventions that exist to address health outcomes, and of course, high quality data that was readily available, right? This is what was used to come up with these 22 factors, all right? Now, we have 6 broad topics that were covered within this, all right? And then once again, 22 factors. So let's go to the next slide. I want to make this easy. We broke this down in the original, all right, CDC Health Disparities Index report. So it was 22 factors. Then there was another one that was repeated in 2013, which took 19 of these and then added 10 new topics, looking more so now at, once again, social determinants of health, such as unemployment. Is that something to ask when I'm getting ready to do a skin procedure on someone in the clinic? Hey, where do you work? How's your job doing? No, I ask those things. Why? Do they work inside or outside? Maybe I need to give them some extra bandage supplies because they work outside at a Home Depot, Lowe's, and a gardening facility where they have direct sunlight on top of their scalp, hence why they had the melanoma in the first place, or the basal cell, whatever the case may be, and I need to make sure they're appropriately bandaged. Wear a hat, things of that nature, right? These are things that we have to ask as primary care providers, looking at the patient as a total person and not just a disease process. All right, so that's what this study did here. Wanted to throw this in really quick, mainly so that we all understand, of course, the federal poverty level. We're not going to go into this. It's very meaty. What we want to show you, basically, the reason why we use that is so that we can identify individuals that meet Medicaid or Children's Health Insurance Program, or CHIP or SCHIP, okay, and the marketplace. So this helps us to determine who falls within that category there, all right? That's the biggest gist of this slide that we want to do, especially for time purposes. So what does that look like with those health disparities? Well, we find that premature death and stroke and heart disease is highest amongst non-Hispanic Blacks, all right? We find that homicide is higher, all right? Over 600 times higher in non-Hispanic Blacks compared to non-Hispanic whites. We look at asthma attacks, all right? It's individuals of lower financial status or the federal poverty level are at higher risk of asthma attacks opposed to those that are in the upper level or have better financial situations, all right? Maybe they have access to the medication, less crowded conditions. Once again, it's not because they're brown or black or yellow or whatever the case may be. It's not a color thing, looking at all the social determinants of health, all right? Even periodontal disease, all right, is another one.
So just briefly, we're primary care physicians, and we help patients regularly for all sorts of healthcare conditions, including behavioral health, supporting their mental, emotional health, and their physical health. But we understand that the mental health may be another social determinant of their physical health. And we see this every day, truly. As an example, if a patient has an anxiety condition or if they're suffering from anxiety, stress hormones are through the roof. And there's certain hormones that are going to affect their ability to control their weight, that'll affect their energy, affect their sleep, affect their ability to function and in certain times when, especially when the stress hormones are elevated, which can then lead to significant health outcomes like increased weight, contribute to obesity, contribute to type 2 diabetes and lack of control of those conditions. And so just as a point, we're trying to be clear that what a very important part of the patient's overall health is the mental health, and it should be considered one of the social determinants of their health and considered when we're considering all of the social determinants of health.
Absolutely. We see this so much now, right? With the current pandemic that we're in, and it leads to individuals are more stressed than ever. Individuals, teachers that have been working for years and years now are deciding to retire, right? Because the stress in the workplace, their class is smaller. However, moving to more of an internet base is not something that they are used to doing, used to teaching in that type of environment, right? So how does that affect them? Well, they retire earlier maybe than they wanted to, but then now our schools are missing out on really good seasoned teachers, and we have younger teachers that are missing an opportunity to have mentorship, right? So mental health, it can lead to a cascade of events. So that's very important here. So as we're transitioning into this last piece here, I'm going to turn this over to Dr. Guerra.
Yes. So our final point was we've had some talk here so far about diversity, cultural, social determinants of health, bias, discrimination, how to overcome these things. We know that that's all very important as it relates to our current point in history, but we know that COVID is on the forefront of our minds. We know that everybody's working together. We hope to do our best to control this virus and eventually get as many people vaccinated as possible. We know that there's a lot of questions on people's minds about the situation, so we wanted to give some information about that and then eventually transition to the questions. We chose Roberto Clemente Walker as our historical person for our final objective point in the talk before the questions, because he was known as he's a Puerto Rican hero for being an outstanding baseball player, but more importantly for being a humanitarian who actually lost his own life bringing relief efforts to another country. And he actually passed away in a plane crash trying to bring supplies to people and distribute things that could help overcome not only financial problems, but health problems that that country was experiencing. And we hope that that historical person could represent what we can do here together, but also as a community to overcome this COVID situation.
Absolutely. Now, this is a very busy slide taken directly from the Virginia Department of Health. And Guerra is going to kind of go through this, some important dates for us to understand as we're transitioning to our COVID portion of this discussion.
So a very, very busy slide. So we wanted to point out just a few important dates to kind of put some people at ease about the timing of the virus situation in general and the development of the vaccine. So the slide, it covers a timeline, as you can see with the wavy depiction, but the points and the dates we wanted to emphasize are the following. December 31st and I believe you can see the mouse circling it, were the first reports. And China notified the WHO about pneumonia cluster in Wuhan, the first reports of the COVID virus in general. And we'll skip over then to January 20th, which, as we think about our own country, the first U.S. reported case was on January 20th of the previous year. And so then we started to make some efforts and learn more about the virus here in our own country. And then what we see here is we'll skip to March 7th, which gets more centralized to what's hitting our home place currently stronger. That's the first report of a Virginia case on March 7th. The next date we're going to skip to then is March 17th. So from the time of the first reported case in general, December 31st, to about 3 months later, we noticed that, well, the beginning of the vaccine development by at least two companies, Pfizer and BioNTech, and they announced their plans to start making the vaccine just a few months into knowing about the virus. We'll go to the next date, which we want to point out, which is May 15th, which was when our former president initiated with his administration Operation Warp Speed, a plan to announce potentially 7 vaccine candidates to work collaboratively to make effective vaccines and then distribute them throughout the country. The next date we wanted to point out is July 27th, which is where we had the first phase 3 studies of these vaccines, which were where we're actually giving these vaccines to live individuals and studying their effectiveness. Following in November 9th through 16th, as you can see, we determined that the effectiveness of the vaccines were about 94 to 95 effective for both of those two companies. And then we began distributing the doses throughout our country, with the first vaccine given, the Pfizer BioNTech vaccine given on December 15th. So all in all, it's a year-long process of knowing about the virus in China to the first dose being given of the Pfizer vaccine. And a lot of steps between as it relates to learning about the effectiveness and the safety.
So this is important. So this slide is long, and not to bore you all, but if we understand the history of what we've recently gone through, but now we got to go back a little bit. We hear, oh, COVID, how do they make this vaccine so fast? And, you know, they rushed it and I'm not getting it and things of that nature. So here's the part where it gets juicy here for you all to understand why so many medical providers are like, hey, I'm on board to go. Back in the day, there was something called SARS, COVID. What, COVID? What do you mean? So if we look here at this, slide here, I want COVID viruses or coronaviruses. There's a bunch of different coronaviruses. If we look over here, then we come down here to something called severe acute respiratory syndrome. That sounds really familiar. Back in 2003, we had something called SARS. Now, it didn't explode to SARS-CoV-2 as we experience now, right? But then in 2012, we had something called MERS, right? Middle Eastern Respiratory Syndrome, all falling under the auspices of the beta coronaviruses. All are coronaviruses. So yes, this is new to us here, but itself is not a new virus. It's a new type thereof, which viruses are known to mutate. All right, this one down here basically shows where they came from or where they believed to have come from, and then how they spread to humans, i.e. MERS, bats, camels, humans. All right, so we felt that this is important to understand, once again, historically where we are, because when we started talking about genetic sequences and mRNA and, oh my goodness, they're changing my DNA, they're putting a microchip in my arm, right? That's some of the things that we would hear. So we don't laugh at those things. We want to make sure those are real fears that individuals have. So we want to make sure that we are knowledgeable on the history, the best of our abilities and the amount of time that we have on a Saturday, right? Presenting this now to our community, those here on the list. Now, due to time issues, we do have 2 very good videos. We're not going to show those here because sometimes I get a little bit of longness of breath. So I've gone a little bit longer than probably should here. So these videos are going to be on the handout sheet that will be distributed to you all with helpful links. What these do break down how the virus was made and what this mRNA thing does. So when Wuhan in China, they distributed the genetic sequencing for SARS-CoV-2, because remember we had SARS-CoV-1 back in the day, SARS-CoV-2, okay? Now we have the genetic sequence. So with that, now we can induce this into the individual, i.e. phase 1, 2, and 3. Third phase, as Dr. Guerra just mentioned, we can now put that into an individual. Now that individual starts to make antibodies against that spike protein we've been hearing about, all right? So genetic sequence, a protein that's given to the patient, not coronavirus. If you get the COVID virus, be it current ones available, Moderna and or biotech, okay, or Pfizer biotech, you are not getting a little touch of COVID virus. You're getting a genetic sequence protein, your body forms antibodies for that, okay? So that's what's going on in that situation, okay? And then your body says, I got soldiers ready. So if I get COVID, because you can still get COVID with the vaccines in your system, you can. Now your body has the army ready to go. They don't need to be ramped up to fight it. 100% efficacy in individuals from developing severe COVID, i.e. ICU, intubated, et cetera, with these two vaccines. So that's very important. All right, so moving along here. So I want to make sure that I don't go over here. We got about another 2 minutes and then we're going to open up the question and answering here. So there's a couple quick little facts here that we want to point out. So where are we now as it relates to vaccines? We got 2 vaccines out. We got one that's coming. I want to say March 22nd. Johnson & Johnson is going to have their information that's going to be released here, which is fantastic information. That's the one shot. That's adenovirus. So a little touch of the virus you will be getting for your body to make antibodies subsequently to fight against COVID. The current 2 vaccines, I want to reiterate this important fact. They are not COVID viruses that you're getting, okay? You're getting a protein. All right, the registration process, oh my goodness, this has been so hard. Our health departments have been so overwhelmed and had to go through so much. Our health departments here in the state of Virginia, we were using something called VAMS. There was a big governmental investment, and unfortunately we realized that product didn't live up to the need that we had. And I will leave it at that. So now we've changed it here in the New River Valley. So New River Valley, or NRV Road to Wellness, okay, is what we're using now to register yourself to get the vaccine. Now, there's been a lot of progress we've made. We were 50th in the country, state of Virginia, 50th. That's bad. I think it's 50 states. That was really bad. But we have transitioned now to in the top 10 as it relates to vaccine distribution. We're talking 130,000 a week. That sounds like a lot. But remember that number I said from the very beginning, 8.6 million people are in Virginia. So if we continue at this rate, we're not going to get out of phase 1B for another 3 months. All right, if we look at big picture. However, that's where we are now. We're getting so much progress. Our health departments here are on top of making sure we can get as much vaccine available as possible. And that has been the biggest limiting step, is access to the vaccine, getting the vaccine. All right. So now we need to make sure that we're patient. All right. We need to make sure that we're patient in getting the vaccine. And that's, I say vaccine privilege is a term. It's going to be probably more mainstream here shortly. Vaccine privilege is a big issue that we're running into. One, and it doesn't mean that you're a terrible person, but it's say, I have the ability, I have a car. I can drive to the local town and get my vaccine because I have vaccine privilege. I have the privilege of a vehicle. I have privilege of internet. I have privilege of literacy. I can go and get it from a neighboring town. But that's not what you should do. That totally defeats the process of trying to follow these phases and getting the vaccine. We want to follow a specific approach, right? So those that are at the highest need get the vaccine first so that they're protected. And we continue to do what we've been doing, which is wearing our mask, social distancing, washing our hands. And then when it's our time to get the vaccine, we'll get it. Okay. So these things are important. That's kind of an airplane view of this whole picture. We did also attach on your sheet that you're going to get. It has a link to the CDC latest updates and kind of where we're going from here. So that's a lot of information on there. This is where the vaccine is currently being distributed. So you can see there's some places that aren't even getting it. And we got to think, should we be distributing it to these places that don't get it at all, right? Is this where it's coming from? Is this where it can come from? Okay, these places that have very limited access. So this is a huge task. You know, it would be nice if we just did it how we did last time we had a pandemic. Wait a minute, it's been a long time. So this is new territory for all of us. We need to be patient. We need to continue to do our social distancing, hand washing, wearing a mask, because we're still gonna be doing that after we get the vaccine. I got mine. You got yours?
Yes, sir.
Right? We're healthcare providers. We diagnose COVID on a regular basis, but we're still wearing masks. And we will continue to do so until we're informed that that's going to change. And I believe that will be quite some time because there's so many people that have not been fortunate enough to not even get 1 dose, let alone you get 2 doses, right? But you're getting that first dose. There's our resources. And just so you know, we are regular people, individuals, just like you are. We're no more special than you are. We appreciate the opportunity. We're in the service business. We enjoy being able to serve our community in which we live, and we're appreciative of that. And then some highlights for back in the day when we were young and active, and hopefully we can stay that way and stay healthy. We want to encourage you all to stay healthy as well. We want to thank you so much. And now we'd like to open it up to questions or comments or what have you.
Thank you, guys. In just a minute, we'll have Holly on as well with you. Hold on just a sec.
Sure, no worries.
Thank you so much. This has been such important and valuable information that you've both shared. And we've had several questions from the audience, and we're going to get to those. I did want to highlight a couple of things prior to jumping in. There were several logistical questions about access to the information you were sharing, and that all of the links to anything that you shared in your slides will be made available to our participants through the worksheet, I think, and through other sources. So we're going to make all of that information available as quickly as we can. And also just one tiny thing about the Road to Wellness site is that the state of Virginia is moving everything to a statewide pre-registration program. So
Yes.
the Road to Wellness site was taken down on Friday night so that that data can be migrated to the state level system. Anyone who has already registered with the Road to Wellness site, your data is being migrated to the state system, and hopefully by Tuesday morning, the state will have their pre-registration site up. I would share a link, but I'm not 100% certain of what the correct link is, and so I don't want to share incorrect data. But again, we'll be making that available through
Yes.
Your participant sharing as we can. As you both have shared, this road is, I loved the curvy sign that the VDH had, because I do think that it is a moving target a little bit. So we're so appreciative of the information that you've shared, and we have many people who have some questions. And I did want to kind of start with, I was inspired by your comment about, Roberto Enrique Clemente Walker's concept of humanitarianism and distribution. And we had several questions about the equitable distribution of vaccine and how you are understanding that. Kind of people had some concerns that maybe looking at it through just a cultural social lens, which I don't think is necessarily what you were specifically saying, but that how are we addressing it from a racial lens, and what are the things that you think we could do better in this area to make sure people who are not just in the lowest socioeconomic categories, but people we know that are brown and Black friends, how can we make sure that those people are getting access to vaccine and vaccine information most effectively?
I'm going to let ask Dr. Guerra to take that first one. I'm going to grab a plug so we can plug in, so that way we don't lose connection. So give me 1 second. I do apologize.
So I think the most important thing is if we have learned some information, not only today, but if we're available resources to share that with as many people as possible. So if we know of distribution centers who are providing the vaccination, give all of our friends and family that information, give them the opportunity to know where and how to contact the right people to get the vaccine. So there are several places distributing the vaccine at the time, at our current time. For example, Blue Ridge Church in our region, Southwest Virginia, is distributing the vaccine. So I encourage us to share that information with as many people as possible. Many clinics are starting to distribute the vaccine as it's being brought into the region in bulks and in certain numbers. So that would be the most important thing, I think, as it relates to getting as many people vaccinated as possible. And I think Dr. Hardee will be back shortly, so he may have some additional input.
Sure, and we can circle back when we need to do that. One of the things also related to vaccines specifically, there were some questions about side effects from the vaccines and concerns people had about whether or not that's something that should be expected, if there's value to those side effects, and also if it's something that anybody would expect to be fixed or not. Yeah.
Absolutely. So great question. There's always a potential for side effect with any medication or vaccination. always a potential for an allergic reaction. However, the majority of patients who receive the vaccine experience some soreness at the vaccination site and some potential mild symptoms of myalgias. But so far, of all the patients I know who've been vaccinated, there's not been any allergic reaction. There's been very mild symptoms at most after the vaccine, and there's not been any deaths in our region or other concerns that people may have. There's never been any correlation between utilization of the vaccine and death.
Absolutely. And just to add to that, we have precautions that we take when someone does have a reaction, which if there is one, the most common, so allergic reactions, so like anaphylaxis or something like that. So an adverse effect would be some stomach pain, nausea, headache, right? Soreness in the arm, but a true adverse reaction, allergic reaction, is we would manage it the same way we would when we have adverse reactions, such as with the flu vaccine, right? So utilizing epinephrine and things of that nature, or someone who has a peanut butter allergy, epinephrine, and then manage it from there. Also, too, adding with distribution, one of the things that will be happening down the road is FQHCs in general will start with some distribution later down the road. But as we move from a CVS Walgreens to one or two local from your health department, then your FQHCs, for the sole fact of trying to reach those high-risk individuals. Approximately 50% of the residents in Virginia could qualify in phase 1B, right? So as I was spitting all those numbers, 50% of those individuals in Virginia could technically fall within that category. At the rate we are now at about 130,000 vaccines a week, right? That's where we are. It's going to get better. It's going to get a whole lot better. All right. Especially with the data entry, as you said, new websites and things of that nature that are a little bit more reliable. All right. And resilient, right? That will change. So that's why it's important now for all hands on deck with the Medical Reserve Corps, be it if you're medical or non-medical, wiping tables down or giving vaccines, just as important as sweeping the floor, as wiping the pens down, right? So all those things are important. So.
Thank you. Thank you very much. There were just a couple of other follow-ups that are maybe on the more medical side of this. Is people are concerned about if they have a cold or if they're maybe not feeling well that day. Is that should they avoid getting the vaccine because of that, or is that something that if they're, what are the underlying health conditions that you might suggest people at least contact their physician about or should be concerned about prior to considering getting the vaccine?
So I like that question. And that's one of the other ones that we have tagged on the little info sheet that hopefully we'll get out to you all is from CDC Side Effects. So here's the biggest thing. If individuals are potentially having some of the following: headache, stomach issues, all right, fatigue, myalgia, right, after the vaccine, oftentimes more so after the second vaccine, where individuals are having some of those symptoms. So if you're already feeling ill prior to the vaccine and then you get the vaccine, is the biggest, we're not worried about you getting sick and death, okay? Let's make that clear, all right? What we're more so worried about is your side effects may be more intense. All right. So your adverse effects that you may be experiencing may be more intense because you're already ill and fighting something off. Okay. So that hopefully answers that question.
I think that's really good follow-up. I was kind of shifting gears just a little bit. Some people are still struggling. I know you mentioned that even after vaccines, we're going to be still needing to mask and to follow, some of the mitigation factors for probably some time. Several people were concerned that they do wear masks. What is your feeling about benefit of double masking? And also, how can we talk to family members who might be less amenable to mask?
Absolutely. You want to take it first? You want to take it first?
Sure, if you want to start.
Okay, sure. The double mask is a question that we get quite a bit. So in the clinic, we use gloves when we do procedures. Now, if we have maybe a subpar glove or a subpar glove distributor or a subpar order, we're noticing we put the gloves on and they happen to rip as you go through, or we take our hand off, we take the glove off and realize, hey, we had our hands in water, but our hands are wet, not from sweat, but they're wet, so they're porous, right? It's not a good glove. Now, wearing double mask, if you are wearing a mask maybe from a local department store that looks super snazzy and it happens to match your pants or it matches your shirt, but all it is a face covering, not a mask. We know that individuals don't have access to surgical masks on a readily available, especially individuals that have financial struggles, right? So a double mask, right, may be appropriate to utilize. Now, I know in our clinic, we don't have to double mask because we're fortunate enough to have the appropriate type mask. Now, we don't walk around with N95s, all right? We don't do that because that's overutilization of a resource. So it's understanding the type of mask. Well, should it be cotton? Should it be spandex? Should it be wool? Should it be a face covering in general is better than nothing. However, now we got to be careful when we say that, right? It says, well, certain types of materials break open the particles and spread them out to other individuals. If we're practicing our social distancing and we're wearing our mask to the best of our ability, doing that is better than nothing. And for individuals that feel as if that is not relevant to that individual, I try not to make people feel bad if they don't want to wear a mask. I just say, think of every person you see as your grandmother or your mom. My mom is older than me, and my mom has other medical issues. My aunts, my uncles are older than me, and they have other medical conditions. All right. I don't want to get COVID, but if I do, I have a higher likelihood of being okay. But those that I interact with may not be in the same circumstance. So I got to treat everyone who's around me as if they have pre-existing conditions that may dispose them to getting COVID. All right. So that's why I wear the mask. All right. That's why I'm careful. That's why I do hand sanitizing. Right.
Yeah, definitely. I agree. I think both with mask wearing and vaccination, it's usually as it relates to the question of a family or friends who are hesitant about wearing the mask or being vaccinated. It's really a discussion of the consideration of the community at large. So if the individual is not concerned, him or herself, about the infection, I encourage the person who is trying to have the discussion with a hesitant individual to approach it from the standpoint of considering the community as a whole, especially the most vulnerable in the community, the folks who have a higher likelihood of passing away or having a severe form of the infection.
Thank you. I know we're getting close to the end of our time, but I did want to give you the opportunity perhaps to suggest ways that groups like the Dialogue on Race or other groups that some have mentioned, groups like Rotary, others that could be the most, what are the things that they could be the most effective in helping both distribute appropriate information and supporting the work in our community, both from the COVID pandemic perspective and health equity information and process that you were advocating for?
I think the term that I would use, and I use this a lot when I have the opportunity to do some public speaking, is dynamic. So as I just gave this very nice presentation, and Dr. Guerra gave this very nice presentation, Holly very eloquently said, hey, look, that dashboard, the NRV Rose Wellness is going to be changing, right? Just as of yesterday. So understanding that this process is so dynamic because it is new. And we have to be willing to adapt to that. Individuals that struggle with adapting to diversity and a changing cultural environment are struggling with the same things as it relates to, I believe, with COVID situation. It's so dynamic. When are we going to have something that's stable? We don't say go back to the way it used to be. When are we going to have something that's stable that we can rely on, right? We're in an unstable time. So what I would like to tell those other organizations that have a captive audience, Lions Club, Rotary Club, other women's organizations in the area, right? Try to make sure that we are encouraging those that we're around, that this is going to be, we say out of the woods, this is going to be a long-term process. We have to make sure that those that have the least opportunity or least access are getting priority. Because if we do that, we will decrease the risk of this virus spreading to others. I can work from home on certain days. Someone who may not have a job that allows them to do that needs to go to the job, needs to go to the factory, needs to go to the assembly line, needs to work second and third shift, right? So they need to work to keep their lights on. So they need to get that priority to get that vaccine, right? They're just as important as I am. I'm just as important as they are.
Absolutely.
Absolutely. Thank you very much. And I know we got through just a tiny bit of the questions, many of which are very specific, and we're going to try to address those. I know you said we'd have to circle back around to your homework that we might offer, but hopefully, would you, I guess I'd like to ask, and with the people who are still on, would you be willing, if we can share these questions to you specifically, to offer perhaps some responses in writing if they weren't too extensive?
Sure. I think if there were questions, what we could do is the same way we're going to do with the other document that was sent out. So they're sent out to everyone and not just that one individual who's maybe asking that question. And then just one last thing, and I want to let Dr. Guerra get a chance to speak here. We have got to do a much better job of supporting our health departments that represent our areas. And relaying a unified message of not talking down, not saying, hey, they should have did this or they could have done that. We have a national issue, then we have statewide. It's doing a little bit different in different places. We're doing the best that we know how. Sometimes, yes, it may not be good enough, right? But if we're in it together and the intentions are good, right, we gotta be able to unify on this. And I think this is going to be a great opportunity for us to do so, because everybody's affected. So I'll be quiet now.
Yeah, please don't. And I do want to make sure that we're at the end of our scheduled time together, and we want to honor that for people who schedule this time to be respectful to our panelists who have given up a lot of time and energy to this work. So we are going to wrap up the formal webinar now. And we want to thank you, Dr. Billy Hardee and Dr. Peter Guerrera, and I think we still have nearly 300. I don't know the exact. I need to look at the exact number. I think I can still see that. We got 200, still 240 still on here with us today. I think we were up over 270 at one point. Again, thanks to the community group in Montgomery County for hosting the dialogue on race, and to the Montgomery County government and town of Blacksburg for their financial help, and to the amazing tech team who makes this all possible and keeps us on task and time. A recording of the webinar will be available soon on the Dialogue of Race website. And for those of you who need to go now, I thank you for engaging with us. This isn't, as we said, for those of you who want to hang around, we'll keep the Zoom webinar open, and I'm happy to answer some specific questions, since I do work with the health department and do work at the Blue Ridge Church at the vaccination clinic, as well as at the call center. If there's specific questions about that, I'm happy to answer those too. But also, for those of you who need to sign off, know that we appreciate your time and engagement, and that this work is ongoing. It's important, and it includes all of us. We are all in this together, even if we're all not doing it the same way. And as a reminder today, it's still our individual and collective work. So stay well, and those of you who do need to sign off, we appreciate your time, and especially to our panelists. Thank you very much.